Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we review and provide commentary on resources, literature, and we discuss issues related to the field of speech-language pathology.
You can use this podcast for ASHA CEUs. Visit our website for other courses, including live courses, webinars, blog posts, and SLP Masterclasses available for graduate level credit. SLP Nerdcast is committed to improving continuing education in our field through affordable pricing and open access libraries. You can support our work by leaving a review, referring a friend, making a one-time contribution on our website, or subscribing. You can subscribe for as low as $7 a month and get access to monthly Q&A sessions, exclusive content, discounts, and a resource library of downloads, freebies, and printables. Want unlimited access to ASHA CEU courses? There's an affordable subscription for that too. For more information, visit us on our website or contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to connect with you.
And just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts, and guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and a fair representation of each topic that we tackle. That being said, it's always likely that there's an article that we've missed or another perspective that we haven't shared. If you have something to add to the conversation, please email us. We love hearing from our listeners.
This episode is brought to you in part by listeners like you and one of our amazing corporate sponsors, MedTravelers. MedTravelers is your industry leader for exclusive allied healthcare travel opportunities. MedTravelers has benefits like higher earning potential, W-2 employee status, and a flexible schedule. Visit medtravelers.com to learn more. MedTravelers did not participate in creating the contents of this episode. Hello, everybody. We're so excited for today's episode. I am here solo today while my counterpart, Amy, is on vacation, but I'm not lonely. I'm not alone. I have the pleasure of welcoming Sara Penrod onto the podcast today. Welcome, Sara.
Hi, thanks for having me. I'm so excited.
We're so excited because you're going to talk about something that I know nothing about. And I think I say that every episode, but I really know nothing about this. You are going to talk to us about the role of the medical SLP in an ICU. And I worked in a hospital, it was outpatient, but I am not a medical SLP. I have never worked in the adult population, much less in an inpatient setting, much less in an ICU. I know very, very little about this. So I'm really excited for you to teach me all the things. And I wonder if before we get started, you can tell everyone a little bit about yourself.
Yeah, absolutely. So my name is Sara Penrod. I work currently full-time at an acute care hospital in Maine, a 637 to 650 bed hospital, depending on the emergency department. We have 6 critical care units at this time that I'll go into a little bit. We have a medical ICU, surgical ICU, neuro ICU, cardiothoracic, cardiac, and currently a COVID ICU, unfortunately. I've been in the field about 15 years. I've always worked with adults. I've been everywhere in the continuum of care. I've been in skilled nursing. I've done a little bit of outpatient. I did inpatient rehab at Spalding in Boston for 10 years, which was a huge learning experience. I worked at a long-term acute care hospital in Boston with a lot of vent weaning and trach involvement, which was really a great experience, especially for transitioning to the ICU. My current interests are critical thinking in SLP and really the importance of the SLP on the interprofessional team. This concept right now of interprofessionalism that we'll get into, where we're not operating in silos, but that we fully understand each other's roles and what each other can offer is my big thing right now. In acute care, we're seeing a lot of, it's necessary to do a lot of advocacy and education for team members. So it's an interesting role. It's as team focused as it is patient focused, which is really interesting. So that's what I do, and I love it. It's just been probably the job of my dreams being here. Fast-paced, acute care, unique patient situations. I mean, I've seen stuff here I've never even thought of. So it's been wonderful. And I'm so happy to talk about the role of the SLP in critical care, because it's something I feel really passionately about.
Well, you've already said two things that really get me going, which are interprofessional collaboration and critical thinking skills for a clinician, which are two things that I don't know. It doesn't matter to me what setting you work in, what population you work with. These are skills that empower us as clinicians that are critical to our jobs that my very humble opinion is that we don't talk about enough. We don't prioritize enough. So I was surprised to hear you say those things as they relate to the ICU, but I shouldn't be surprised because they're so important. So I'm really excited to talk a little bit more about that just selfishly, because I also find that very interesting and as a critical piece of our clinical lives. But before we get into all of the really fun stuff, I have to read the learning objectives and our disclosures. Sometimes people write in and ask me to skip this part. I can't. Asha makes me read it. So please bear with me. I will try to get through it as quickly as possible. Learning objective number 1, identify ways the SLP can address speech, language, communication, and swallowing disorders in the ICU. Learning objective number 2, list the reasons for obtaining and synthesizing the most up-to-date medical information before seeing a patient in the ICU. And learning objective number 3, list factors that can contribute to success in therapy or confound SLP-specific diagnoses. Disclosures: Sara Penrod's financial relationships. Sara is employed full-time in an ICU setting. Sara Penrod's non-financial disclosures. Sara does not have any non-financial relationships to disclose. Kate, that's me. Financial disclosures. I'm the owner and founder of Grand Bois Therapy and Consulting, LLC, and co-founder of SLP Nerdcast. My non-financial disclosures: I'm a member of ASHA SIG 12 and serve on the AAC advisory group for Massachusetts Advocates for Children. I'm also a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, the Association for Behavior Analysis International, and the corresponding Speech Pathology and Applied Behavior Analysis Special Interest Group. Okay, now that that is out of the way, I am so excited to learn all about this because I have never worked in the medical setting and I have absolutely no idea what you do. And I have to assume that out of all the SLPs in existence, it's likely a relatively small percentage of SLPs who work in an ICU. Is that true?
Yeah, I mean, if you think about the statistics of our field, right? So many thousands of SLPs, half of which or more work in schools. You and I talked about this earlier. I think I don't even know what the numbers are, but it must be very small.
I have to assume so. And I'm wondering what qualifications an SLP needs to work in this environment. It just seems like such a specific, substantially separate environment from what we're trained on in graduate school.
Yeah, so that's a really interesting topic. There's no specific training or specific education portals for being an ICU SLP. It's usually hospital dependent. You get your feet wet kind of on the regular floors. You learn about the medical systems of the body, and then you start to treat the more medically complex patients. I mean, I think people who haven't seen really critically ill patients get super nervous. If you walked around any of our ICUs, you would see so many patients ventilated and intubated and, so many lines and drains and super sick, the nurses right at the bedside, often the team right at the bedside. That's extremely intimidating and overwhelming. And there's not specific, outside hospital training, but if you're working in the hospital, there should be, orientation process or a mentorship program or something. Hospital shouldn't just be throwing SLPs into the ICU.
Here for mentorship. We talk about that on the show all the time. It's so important and such a critical piece of our field we find is missing. But honestly, if I start talking about that, I'm going to get on a real big soapbox. So I'm going to move on.
Understood.
Something that you just said reminded me of something that we talked about, actually, I think before we hit the record button, in that the patients that you see in an ICU are the same patients that you see in acute care, right? They're just much, much sicker. Is that an accurate description?
Absolutely. So, think of your caseload at a rehab or at a skilled nursing facility, and you're reading through this chart and you're reading about these weeks or months of critical illness, debility, deconditioning, multi-system failure. The kidneys went, the lungs went, they needed a trach, the trach is out. These are the patients that we're seeing when these events are happening. So when these acute changes are going on day to day, and at times patients are really tentative on survival. So it's a really fast-paced environment. But when you think about the scope of what the speech pathologist does,
it's all the same domains, communication, cognition, motor speech, swallowing. They're the same areas that we're working on, just bringing them down to the level that the patient is at, either medically, physically, both.
That was going to be my next question. And it wasn't going to be a very intelligent question. So I'm glad that you've prefaced it with some information to make it sound like I know what I'm talking about. But in my imagination, having not spent a lot of time on an ICU, fortunately, and having never worked in a medical setting, these patients are critically ill. I mean, they're in an ICU, right? Like they're very, very, very sick. So I'm making the connection in my mind that as an SLP, it's still our same domains of practice, but what is our role in terms of treating someone who is so critically ill? What is it that we actually do? I say we, like I'm there with you. I'm absolutely not. What does
You'd be welcome here anytime.
Thanks so much. But what does the SLP do in an ICU with patients who are so critically ill?
So a huge part of what we do is education and advocacy. It's a huge part of what we do. We're looking at patients who are not ready to eat for the most part. We do have some eaters in the ICU, but we're thinking about long-term plan versus short-term plan. Okay, are we thinking this person's going to be able to eat in the next couple of days, or are we thinking weeks or months? Speech pathologists are highly involved in trach management and critical thinking related to the decannulation process. So when is it appropriate for the cuff to be deflated? When is it appropriate for a speaking valve to be trialed? And then once the medical stability is kind of there, you're looking critically at the swallowing. You may be starting with secretion management. You may be starting with pre-feeding, arousal, and cognition, in the context of dysphagia, because maybe they don't have a cognitive disorder per se, but they may be delirious. They may be have medications on board that are keeping them sedated. So it's not a cognitive problem per se, but other issues that impact their readiness to take PO. We're looking at communication assessment. I mean, obviously we're seeing a lot of really large bleeds, which can impact all aspects of communication, language specifically, motor speech dysfunction. So you're looking at not only what their preserved and current communication abilities are, but what might they be needing in the future. So you're looking at low tech versus high tech AAC communication. These patients are changing really daily, sometimes for the better and sometimes for the worse. So you're trying to make these predictions like in the context of everything else that's going on. We certainly can do formal cognitive assessment in the ICU. We do have a protocol where patients who've undergone cooling after cardiac arrest will get a CLQT, a cognitive linguistic quick test, and that's it's involved in a study for long-term data, looking at latent cognitive effects in patients who have cardiac arrest and require cooling. But there's other cognitive assessments that we have readily available as well. Usually in the ICU, patients are, like I said, they're just not ready to participate in that. And if they are, they often throw you out anyway, like, I'm not doing that right now.
Right.
So you have all the tools in your toolbox, but it depends on the patients and how sick they are. And, for a lot of these patients, working with PT for 30 minutes might be it for the day, and that's it. PT will tell you, oh, they did great, and you'll go in and they're like, I can't do anything else today, and that's not uncommon, and it's not that surprising when you're looking at their labs, you're looking at their overall medical status. It takes a lot more for them to do some of those basic functional things than it does for some of the patients on the other floors.
Interesting. Now, in a previous conversation, I know we talked and prepped so much before this episode, you mentioned delirium and the role of the SLP in delirium. Can you talk a little bit about that? Maybe define delirium?
Sure. So delirium is considered a serious disturbance in mental abilities. It looks like confused thinking and reduced awareness of the environment. It usually onsets really rapidly, and it can kind of fluctuate. It can fluctuate from day to day. It can fluctuate from hour to hour, depending on a variety of things. A lot of times the contributing factors are just critical illness, which is most of the patients in the ICU. But then these patients are also undergoing changes to their metabolic status, which can impact delirium. There's a lot of rapid medication changes that are going on. These patients are often dealing with infection, which can be a contributing factor. The process of undergoing surgery and having anesthesia can impact this. Drug or alcohol intoxication and withdrawal. So all of these combinations of things that can kind of ruin a patient and then start to look like cognitive, changes in mental status and cognitive abilities. So they often have poor arousal, poor attention to even basic tasks. And sometimes on the opposite, they're a little bit withdrawn, like maybe over sedated, this hypoactive delirium. These patients are often restless. They may be seeing things in the room or in their bed. That's a creepy thing when a patient's like trying to pick spiders off of you.
Oh my
it's like,
gosh.
okay, this poor person. Sometimes they're calling out. Sometimes they're not responding at all. They're often very lethargic. Their sleep-wake cycles are often impaired. So all of these things, it's interesting, you're not really diagnosing a cognitive disorder, but for all intents and purposes, for participation in basic functional tasks, answering questions, following directions, being oriented, these things are, significantly impaired. So, you're sort of, as an ICU SLP, you're kind of monitoring the delirium through the lens of medical status. So you're like, oh, well, I can see by the labs that the kidneys are all out of whack, and the nurse says that they haven't slept in 3 days, and they're changing all kinds of meds, and or the person is withdrawing from alcohol or drugs. So, you're kind of monitoring it, and you're trying to come up with environmental ways to improve overall functional participation, but you're not quote unquote treating cognition per se. But for a lot of those patients, they're not ready to eat, and they may have a perfectly functional swallow, but for obvious reasons, you don't want to be feeding those people. So it's a balance.
You mentioned a lot about, reading labs. And I know that this is understanding a patient's medical status, because it can fluctuate so quickly, is a critical piece of what you do. And you made our listeners these beautiful handouts. These handouts are so beautiful that a whole series of text messages and Slack chats happened afterwards amongst the SLP Nerdcast team, because we were so impressed with these handouts. Do you want to tell our listeners a little bit about what you've included in these handouts so that they know what they can find in terms of, I bring it up because you mentioned the labs, and the labs are a big piece of what you've offered our listeners.
Yeah, absolutely. I included just sort of a basic handout on what a lot of lab panels look like in different hospitals. And I did specify that depending on the lab within the hospital, the ranges may vary, but when some of these labs are abnormal, what your patients might be looking at, or rather looking like. So if patients' blood counts are off and there's concern for a GI bleed, that person may not be appropriate for eating. Patients who are having, kidney disarray and metabolic disarray may be more confused. They may be lethargic. So, not only when you're going to see your patient for the day, you're checking in on what their medical status is as a contributing factor to what they might look like in your therapy session, but you also may be deferring a person for that day, in combination with a conversation with the nurse. But, all of the systems in the body sort of start to snowball when a person is critically ill. It's not just, oh, this person has respiratory distress, so their lungs are impaired, but everything else is in tip-top shape. What makes a person critically ill is that when one system starts to go, other systems start to compensate, and then everything is working not at full function, so then everything starts to decline. So when you understand pieces of this system and what it might make your patients look like or feel like, or present like, it kind of helps you plan your treatment sessions or predict, how long until a PO diet, or how long until this delirium may clear, for example. And all of those predictions, I say, are extremely difficult, and there's no, one lab value that's like, oh, I see here that this person's dysphagia lab value is off. That's not the way it works. I wish there was an easier way. But looking at the big picture of the body really can help you understand what is going on with your patient. And then, talking to the team about, well, what are we thinking? Oh, we're going to do a blood transfusion for this person. Oh, there's potential then that they'll look better in 12 to 24 hours. So I won't see them today, but I'll come back and see them tomorrow, later in the day. They might be tired in the morning. You're kind of planning based on medical care and based on medical systems to the best of your abilities.
The training that you have is just so, every time you open your mouth, I'm impressed. There's just so much knowledge. There's so much you have to know to be able to do this job well. And I'm so grateful for your efforts to create these handouts for people to listen. So if you're listening, they're available for download. She made them, they're free. as a nice little handout for you to have at your desk or your station or wherever it is that you're working. Another component that I keep thinking of while you're talking is this concept of collaboration, because if you're talking about the labs and the patient's current status, you need to be talking to your coworkers and learning from them and talking to the attending physicians or the rest of the medical team. And I cannot imagine a scenario where you can be successful in this work setting without collaborating really closely with the rest of the medical team, or creating documentation if to communicate in an asynchronous way, if you can't, stop to chat with your colleagues in the hallway. Because it sounds like a lot of these decisions, there's a ripple effect. It's influencing a lot of other variables that are happening in the ICU. Is that an accurate reflection?
Oh, 100%. And I think you probably spend as much time in critical care looking at the chart and communicating with the team as you do with the patients. I mean, these patients they are critically ill. They're significantly weak. They're very deconditioned. There's not always a whole lot they can do, but you are spending a significant amount of time advocating for them and problem solving. I mean, some of the patients that we're seeing with COVID, quick respiratory failure, the team is doing so much to keep these people alive and keep them breathing. So whose job is it to think about what the swallowing might look like when this is over? A lot of times they're not thinking about that in the moment. So families are having conversations about, will they be able to eat? When will they be able to talk? Looking at patients, even when they're on the vent to sort of predict some of that swallowing physiology in the longer term care. I mean, this can lead to avoiding PEG tubes, long-term feeding tubes for some of these patients. So
this brings me to a question about something that you mentioned before we hit the record button, before we get into our second learning objective. You mentioned how important it is for the SLP to get involved early in the ICU stay. Can you tell us a little bit more about that?
Yeah, I mean, it's really important that the team and the families understand, the plan for eating and the plan for communication, how the speaking valve works, for example, ways that the family can communicate with the patient. We didn't even get into really any of the language assessments or the AAC assessments.
Oh, we still can. We'll make time.
Good.
It's good.
Yeah, okay.
I derail with questions all the time. It's cool. We'll get back to it.
No, I love it. But yeah, so the importance of getting in there early, a lot of times patients are trying to communicate or asking for ice chips. And, based on chart review, you might say this person is not appropriate to eat, but you say, okay, can I clear this person for ice chips and reduce their frustration, reduce their anxiety, improve their oral care, improve their, the oral bacteria in the mouth just from the natural process of swallowing. I mean, that's so key. Not to mention, how crazy would you go if you couldn't have any moisture in your mouth aside from like a green sponge?
I don't want to think about it.
Oh, I know.
I don't want to think about it.
I have the most sympathy for patients when they're like, I just want a big drink of water. It's like, heck yeah, you do. You and me both, So, and it goes back to that reducing of delirium potentially. I mean, there's research showing that early SLP intervention can help shorten hospital stays, shorten time to decannulation, shorten time spent NPO, potentially, shortening time spent with dysphagia, potentially avoiding long-term nutrition placement, with being able to modify a diet texture or such things. So, and it's really helpful, even if you're not seeing a patient consistently, it's really helpful to be able to be reviewing the chart and communicating with the team like, hey, I don't feel safe seeing this person right now, but here are my parameters, so that the team is not just wondering and not just, arbitrarily placing a peg. It's like, oh no, speech said, once they were doing pressure support on the ventilator, or once they could sit upright for 20 minutes, that they would more aggressively assess the swallowing or assess the communication. So it's super beneficial just so that the team knows kind of what's the trajectory here. A lot of times I'm saying, this is not safe because, patients on 100% oxygen, they can barely catch their breath with one episode of swallow apnea. But if you can get them down to, a certain amount, 50 liters, let's say, and they can tolerate, PT and OT mobilization a little bit more, that's my parameters for this patient or whatever it is. So everybody's on the same page.
Again, that collaboration piece, I mean, that's got to be so important.
It's totally necessary. Yeah, you can't operate in a silo. And we have a really good communication system with our physicians that we're able to just chat them really quickly and say, hey, these are my thoughts, which has really, I think, changed the practice, just to be able to summarize concisely, this is what I'm thinking, and say it in a more direct way. It's been really wonderful.
That's awesome. Well, I wonder if you could tell us a little bit more now about the language assessment and AAC assessment components.
Yeah, absolutely. So there's sort of two camps, right? There's this camp of patients who have like a true language disorder, like a left MCA, CVA, or, sometimes you're seeing that with those right-sided strokes, significant dysarthria, you're seeing apraxia. So you're sort of conducting it just as you would in rehab or in a skilled nursing facility, keeping in mind those medical aspects, what lines are in place in the patient's room, those kind of safety parameters. But then you're really looking at language sort of the same way, is this person awake long enough to communicate, or is arousal the issue? Can they follow directions? Can they answer yes, no questions? Are they able to make their wants and needs known? And then there's sort of this other side of communication that's really, is this a medically induced communication disorder? Sometimes you're seeing, it's not really dysarthria, but it's certainly a motor speech communicative efficiency issue because of significant deconditioning, or significant lethargy, or overall, significant physical weakness, or low effort on the part of the patient, where it's like, I don't even have the energy to communicate at the sentence level at this point. A lot of the ventilator patients, no communication deficits per se, but they're so weak that it's even difficult to mouth words. You know what I mean? So helping these patients, some of the patients who maybe have a little bit better mobility are able to use letter boards, or there's a couple of apps, like I think it's Passy has a type to text for patients who are tracheostomized, that can just kind of type and chat as they go. That's really efficient. But then there's, the other medical aspects. So when patients are not just deconditioned, they don't have the pulmonary drive to have their voice come out clearly and audibly, or they don't have the endurance and the stamina to produce, output at the phrase or sentence level. So you're giving the staff often tips on how to ask questions that sort of maximize their communicative efficiency.
You've used the word deconditioning a few times. I've never heard that word before, and chances are I've never heard it. Someone else hasn't heard it. So I'm going to ask you what it is.
It's so funny, the things you take for granted, isn't it? In what you do every day.
I've never, and then a few sentences ago, you used the word deconditioning, which I sort of assumed was a strength related issue, but then you also talked about weakness. So what is deconditioning?
So patients, there's all kinds of stats on this, and I don't know them really off the top of my head, but so that as we age, our muscles just don't function the same way, right? And they get weaker at a certain rate.
I don't want to think about it, but yes.
Okay, I was just going to say, I think it starts at 40 and your muscle strength and
I don't want to hear about 8%. That. I won't tell anyone my age, but
I think it doesn't start till like age 70 or 80. So I think we're all good here.
Perfect. Moving on.
But patients who naturally lose a bit of strength and endurance every year to a certain degree, it's exacerbated when they're in the hospital, because they're in bed and they're not moving around, and the muscles, their strength and functioning reduces precipitously when they're not using the muscle. So the like use it or lose it scenario is precipitously worse for someone who's over 70. Add into that critical illness, right? So changes in their oxygenation, changes in their metabolism, the way they're processing food. Add to that, there's probably potentially some degree of pre-frailty or frailty. The body's not processing nutrition the same way. There's probably oftentimes underlying medical conditions that are causing all of these things that people can kind of function with can get quickly exacerbated with a critical illness. So think about like a stroke or a cardiac event, underlying like diabetes or underlying hypertension. These are all going to kind of put people at risk for more rapid deconditioning. Your question as to deconditioning versus strength is a really good one. And there's a lot of talk in that in our field right now, because can we talk about strength if we're not doing manometry, right? Like if we're specifically talking about oral pharyngeal strength? Can I say a person has weakness by looking at their swallowing if I'm not doing manometry? There's kind of this conversation.
What's
going on
manometry?
So manometry is when you would like stick almost like an NG tube down someone's throat, a manometer, and have them swallow. And it basically has these sensors all the way down the manometer that actually says, okay, how strong is the pharyngeal squeeze or the base of tongue? I think it started with esophageal manometry because there's all these issues with the esophagus, right? How do we assess it? So the tube that goes all the way down the esophagus, and then when there's esophageal peristalsis, it monitors, and you actually get this readout of where the muscles are working. Oh yeah. Oh, we could do a whole podcast on the esophagus.
I know. I'm sorry. I keep derailing with my very novice questions, but okay. So you were talking about helping patients who are, having a hard time communicating for either communication disorder reasons or other medical reasons, and using additional external supports like typing or an app to help facilitate more communication while they are in an ICU.
And a lot of times in the ICU, the patients are kind of dependent on their caregivers. And we see this a lot of times in institutions, unfortunately. But so providing that education to the nursing staff, encourage the patient to give, shorter responses to save endurance, or asking yes, no questions to kind of maximize, to making sure you're both on the same page and that things are not getting lost. We often get consults for communication boards. I think this is true of anywhere that you get a consult for a communication board. There's just so much that confounds a patient's ability to use a communication board, vision, obviously, desire to use said communication board, underlying receptive and expressive language. All of that is just made worse in the hospital. So AAC is a great place to start. It's really tricky. A lot of these patients are just too sick, or they're only awake a certain amount during the day. So we do spend some time. We've been consulted a couple of times to do language assessments on patients who are intubated, when the team is trying to gauge whether or not the patient is consistently answering questions. Would you want a tracheostomy tube? Would you want a PEG? Do you know this person still has capacity, but we're sort of trying to get the idea, are they consistently responding? So we've been asked to assess there a couple of times. There's tons of resources for ICU, letter boards and low-tech AAC. It's just, it is a unique patient who can consistently and effectively use it, we've found.
Okay, that's really good to know. And I wonder if now is a good time to start talking about our second learning objective related to you've talked about all of this data that you're surrounded by, all of this information that you're aggregating across different team members, and how do you efficiently do that in the ICU?
Yeah, so like I was saying, you really do spend a ton of time on the chart. I mean, in the chart, reading and sort of synthesizing in your own way. Before I go see a patient in the ICU, I always do a chart review. I mean, that minute, not even in the morning before I make my list, but directly before I go see the patient to check their labs, check their vitals, and then check in with the nurse, try to get an idea of what the plan is for the day. So is the patient having a procedure? Are they, are there positioning restrictions because of blood pressure issues, or an extraventricular drain that they can't be moved because pressures in the head are being monitored, stuff like that. So really up to the minute. And then you're looking at what the team is planning for the day. So sometimes you'll see in the notes that the team is, considering a long-term feeding tube placement. You're involved in some of that decision-making sometime. What are the ventilator weaning plans for the day? A person's going to come off of the vent today. Maybe it would be a good time to take a look at them off of the vent. A lot of the medication changes, are they lightening the sedation? Okay, they're going to turn off the sedation at 10, maybe noon would be a good time to see this patient. So sort of hour by hour, things can be changing for these patients. So you're working with the team's overall plan for their medical stability and recovery, the nurse's plan for the day, the patient family coming in to visit, and family members having questions about what they can do, et cetera. So it's a lot of back and forth. It's a lot of rescheduling. A lot of times you make a plan in the morning and you do not stick to it even slightly because things are changing so rapidly.
And I wonder if you could talk a little bit about the role of counseling. You've mentioned communicating with caregivers and families, and I have to assume that these individuals are grieving. They're scared. Their loved one is in the ICU for whatever reason. Do you find that there are a lot of counseling components involved in this job? I mean, I have to assume yes, but maybe you can tell us a little
Yeah.
more about it.
We just not long ago reopened to family visitors. We had been closed in the ICU for a while for COVID reasons. And it's sort of like, whoa, I forgot what it's like to have family at the bedside. You know what I mean? Especially in critical care. Yeah, there's lots of counseling. You're kind of having a similar conversation with the family. Where do you think that their swallowing and communication is going to go? I often talk to families about what they'll see in rehab, especially if patients don't seem to be progressing that quickly in the hospital. I build up rehab and talk about things that they'll work on in rehab to try to, give families, have them hold on to hope and remind them that this is a very different loved one than you will see once they get to rehab or once they even make it to the medical floor and out of the ICU. I talk a lot about swallowing recovery and things that impact impaired swallowing. So a lot of times, like I said, for these ICU patients, they're super sick. It's not, it causes a secondary dysphagia, yes, but it's not like, sometimes you're suspecting or you're finding that the actual physiology is fine, but because this patient can't coordinate breathing and swallowing, or because they can't stay awake for 5 minutes, or because they don't have the endurance to take more than a few sips, they do require either a modified diet or a feeding tube. So you're sort of making sure that they understand that this is not you're not going to eat again. A lot of this is made worse by your current medical or current pulmonary issues. And I find patients and families really appreciate hearing that kind of information. Like, okay, you're not allowed to eat, but it's because of these other reasons, not because you can't and not because you never will again. And same for communication, a lot of times it's around the tracheostomy tube and the ventilator. We talk about when the patients will be able to use the speaking valve and how they'll be able to communicate and other things that, strategies for other types of communication. So we do more so now than, even a few months ago, but it's good to have families back in the room. You can see the difference in patient responses consistently.
I bet. I'm also thinking about, this concept of synthesizing information in an ICU, because this is a situation where a person's status is changing hour by hour sometimes, I assume.
Oh yeah, definitely. Yeah. And a lot of this, you and I talked about like the critical thinking aspect.
That was going to be my next question, is this, how that relates to critical thinking?
Yeah. So I always think of this concept in the ICU, what is causing what, you know what I mean? So a lot of times patients have aspiration and pneumonia and dysphagia, but which caused which, you know what I mean? So sometimes patients are developing a pneumonia, which can change mental status, which can cause aspiration. Then now that you've got this diagnosis of dysphagia, sometimes people are in with all kinds of GI stuff, abdominal stuff. You've had nausea and vomiting. Now you've got pneumonia, and now you've got, difficulty breathing. And now actually you really can't swallow because you actually can't breathe and your body can't tolerate that swallow apnea. So, that synthesizing the information, again, you're looking at, okay, what are the events that were leading up to this pneumonia? And the research of John Ashford, he always talks about pneumonia being an opportunistic secondary dysfunction. So these patients are critically ill, and then this pneumonia kind of develops in this opportunistic way. So you're really, I think, trying to get an idea of the chicken and the egg, what is causing what for these patients. And that helps you prognosticate, and it helps you talk to the team about what you're seeing, because you're able to give, the big so what, yes, this person's on honey thick liquids, but so what, and why, and what does it mean to the team, and what does it mean for the patient's care ultimately.
That's I love this concept. Critical thinking is such an important piece of what we do. And I'm not sure that we're explicitly taught how to prioritize information. I also heard, this is my new favorite acronym, POEMS, patient-oriented evidence that matters. And it comes out of research from, I think, pharmacology. about how to prioritize different, or no, it's not pharmacology. It's medical data management. This is like a whole area of research that I randomly recently stumbled across. And it's related to what you're talking about in terms of exactly what you said. So what matters? What is the information that you have that matters? And there, it sounds like you're in a work setting where the data that's coming at you is just massive. That's way more data than I get about my pediatric kids, my pediatric clients who are changing, but not hour to hour. The hour to hour change in a pediatric client is, are you hungry and ready for snack? That's it. I mean, not to say that there aren't medically complex, pediatric kiddos out there, but this is a very different work setting that you're in, constantly trying to aggregate information and prioritize it.
Yeah. So you're starting in the day with a chart review, but to your point, I mean, sometimes you're literally going up to some of these units and you're walking around the unit to get to eyeball these patients, because sometimes the chart, you suspect, oh my gosh, this person has been through so much. They're going to look absolutely terrible. And you go in and they're out of bed, they're in the chair. I mean, they're the lines and the drains and the alarms and sometimes the IVs. I mean, you see a wall of 15 IVs running at one time. You know what I mean? So to a certain degree, it just takes getting used to, because you're like, I could see a novice clinician being like, none of these people should eat. None of them should have speech, but you do develop a certain, desensitization to that kind of stuff, which I think is a good thing for the patients and comes with experience. Because you're like, okay, well, let me get in there. Let me move some things around, see what I can do. But then sometimes you do a chart review and you're like, oh, it sounds like this person is going to be ready for a cheeseburger, and you go see them and it's just, they just look terrible. And that's that deconditioning and weakness that we're talking about. How frail is this person is hard to gauge just by chart review alone. So a lot of times you'll go up and you'll say, okay, this person looks like they're ready for speech by chart review. I go up, they physically look like they're ready. I talk to the nurse. Oh, we just had to put them on a bunch of sedating medications because of X, Y, or Z. It's like, oh, okay, I'm circling back, try back at 2 p.m. Or this person might go for a procedure, so they can't have anything. So, you can see them a little bit, but it won't be a full assessment. And then you're kind of gauging like, oh, okay. Oh, this person's ready to eat, but they're not allowed to sit up because they have to have their spinal x-rays and they have to be cleared to sit up. Okay, well, if we're going to feed them later, then we'll just come back later. So I can't impress upon your listeners how intense it is to be up there in those units. And I say up there because ours is the 6th and 7th floor, but they can be on any floor. But just to even be walking around and you really get a sense of the gravity. There's multiple interprofessional teams everywhere. The docs are constantly rounding. They're rounding with clinical dietitians, with clinical pharmacists, with the nurse. I mean, it's a huge team of anywhere from 8 to 10 people. Sometimes you have the specialists, pulmonary is rounding with the teams. It's really intense. And to think that each of these team members has we all have our priorities for these patients. We all have sort of these agendas we want to push. I want my patients to talk and communicate and eat. Pulmonology wants their lungs to be clear and their breathing to be at a certain level. So it's intense. It's changing a lot, but there's so much room for speech to advocate, really advocacy and education. Because like I said, you think that, I don't think this might have been before we were recording, but you expect physicians, these people are some of the brightest minds in their fields. You expect them to understand the weeds of swallowing the way I do. I expect them to understand, swallow apnea and the effects on pulmonary functioning. And it's really not the case. I mean, we really are specialized in this area and really do think about swallowing physiology and the impacts hours every day. And the physicians have an understanding, but it's not the same as the critical thinking that we're expected to bring to it. So it's wonderful. Obviously, I love that your podcast is SLP Nerdcast, because I'm like, love to nerd out so hard.
Well, and I'm learning as I'm talking to you that you are maybe in like nerd supreme, which is a a title we have yet to dole out. So congratulations. You're just all this information. I mean, maybe it's because I don't work in this setting, but this is like an incredible amount of information that's being thrown at you. I mean, you used the word intense and high energy, I think, before describing this work setting, and the way that you're doing such a great job describing it in terms of how much data management you're doing and how much critical thinking you're doing on a, I don't know, minute to minute, hour by hour, on a routine, repeated basis across your shift. And I have to assume that data management and technology are a huge component of this now that most of our hospitals have moved over. So when I started working, I was at an outpatient hospital. We used paper. That's how, not that I'm aging myself, but we did. And then they tried to make us use an LMR or an EMR, and everybody was grumpy about it because we knew how to use our paper and we didn't use dictation yet. But now that we have these data management systems and this chat feature that you talked about, I mean, I guess because I work in assistive technology, it's making me sort of interested in it, but that must be a critical component to be able to digest and analyze and prioritize this information, since it's so fast paced and things are changing so quickly.
Oh, absolutely. Yeah. I mean, we could go into good and bads about electronic medical records, right? But yeah, it's totally necessary. And there's a couple of features in the system that we use that help keep up to date with like labs and vitals and stuff like that, minute by minute. Also, the nurses in critical care are just, I mean, you think I have an understanding of medical aspects. I mean, these nurses are phenomenal. Their understanding of meds and dosages, and they have such a unique ability to synthesize this information differently because they spend so much time with the patients and they have to do so much functional care with them. You know what I mean? So sometimes, we're the communication specialists, but if I'm not getting something out of a patient, I'm definitely checking in with the nurse. Like, I'm not getting anything. Like, are we concerned about a change in status here, or am I not doing it right? Oh no, this patient, if you go to his right because he has an old, war injury and he can't hear out of his left ear. It's like, these are the things that sometimes are not in the medical chart that the nursing staff knows because they're doing all this problem solving and trial and error before you even get there for hours and hours and hours. So the nurses are such a resource. They're really wonderful. Actually, we have an SLP here who is now a critical care nurse and used to be an SLP, which I think is such an interesting transition. Yeah.
Wow. Good for that person. That's a double threat right there. That's a lot of
really good
information.
Yeah. Bedside swallow screen. I got it.
Wow. That's really impressive. That's really impressive.
Yeah.
Do you want to tell us a little bit about, the transition to the SLP's role in therapy, or the SLP related diagnoses that happen? I'm just thinking about our third learning objective, and I have a sneaking suspicion you have another well of knowledge to share with us in this area.
Yeah. So our third learning objective is sort of the factors. I was thinking things that like confound the diagnoses.
Sure.
So this is kind of like, what I was thinking is what we were talking about, like what's causing what, right? Like all these things that can impact your ability to do therapy and your ability to make diagnoses, right? So the nutritional lines that a patient has, for example, they may not have alternative nutrition in place. So once patients are extubated, oftentimes the oral feeding tube goes with it. And oftentimes the team wants speech to look at them before they decide, okay, are we going to put in an NG tube, or are we going to put in, a PEG tube, a more permanent solution? But there's a million reasons based on chart review that you don't want this person to eat. So a lot of times the medical status is confounding. It's like, yeah, this person might be able to swallow, but their medical status, they cannot tolerate a drop of aspiration. So I don't even want to give them more than an ice chip or a drip of water or something like that. Sometimes they have lines that restrict their positioning. Like I said, the ventricular drains, if they're draining CSF, patients have to be clamped to be moved. They have what's called an arterial line, which is a line that goes, it's a catheter that goes directly into the artery that tracks the blood pressure closer to the source. And that line has to be moved with the patient. It's on this like little chip clip thing. So
no one can see my face. My eyes are getting big. I'm like, oh my God, that is very serious stuff. That's very serious stuff. And I hate to simplify it into that, but this is, you're talking about, I mean, you're in that, this is so redundant. You're in an ICU. This is life and death. I mean, this is critical medical stuff. I mean, I've known that the whole time, but when you start talking about arterial lines and needing to get clamped, I mean, I just have to assume as an SLP, trying to not only aggregate all this information, but prioritize it. Yes, you want your patient to communicate, but that might not be the top 10 things that 50 things that the team is worried about. And trying to find your place in that, that's a whole other skill set.
Yeah, it really is. Yes, so a lot of times what's confounding either your diagnosis or your ability to treat is just these complex medical situations. And that's kind of where you get into this critical thinking, because you're like, based on chart review or based on how someone looks, it can be very easy to say, no, not appropriate, not safe. And I think you could make a case for no SLP in the ICU for that reason, but that doesn't help our patients, and research is showing that. So, learning how to work the equipment, learning which patients are safe, learning how to move them, or just completely deferring to the nursing staff is okay too. A lot of times they're 1-to-1 nursing ratio or 2-to-1, 2 patients for 1 nurse. So they're a really good resource. They're there for you. They have time. Most often when you go up to see a patient in critical care, the nurse is already in the room. They're always easy to find and easy to locate. So they're a huge resource. So you're asking this patient, the nurse, I often will ask them, how do you think they'll do on swallowing, or what communication needs do they have before I go see them? It often doesn't change whether I'm going to go see them or not. But I think it adds a piece to the picture, right? Like the nurse is like, oh, I think they're going to swallow fine, but they're on all this Dex. So they're totally sedated. So it's hard to catch them when they're awake.
What's a Dex?
Dexamethasone is a sedating sedating
Oh, it's
medication.
a drug. Okay. Moving on.
Yeah.
Sorry.
Yeah. Right. All this common terminology. It's like,
no, it's fine. I mean, it's one of those things where, there are probably a lot of people listening who work in a hospital who knew exactly what that was, but
like,
I had to ask because I don't.
I love it. Yeah. So, okay, so this patient is totally sedated, but I think they swallow fine. This is one of those confounding factors where it's like, okay, what do you do? You're talking to the team. How long are we thinking this person's going to need such significant sedation? If we're thinking a really long time, then maybe a PEG is the way to go. If the person's alert and awake for maybe a half an hour a day, should we put them on a diet so that they have something to do to sort of reduce their restlessness, reduce their agitation, improve normalcy and routine and oral care and oral comfort, even though you're not anticipating this is going to sustain their nutrition. And a lot of days you're going to have to hold off because maybe the arousal isn't enough. But the swallowing physiology supports eating. So what can we do safely in an environment despite all of these medical factors?
And I also have to assume that in terms of the SLP's role in the ICU, let's say you have a patient who is, very complex, very sick, is very fragile. And through your data analysis and critical thinking, you've determined that working on your goals is really not a top priority. I have to assume that even if it never really becomes a top priority, your presence and role on the team in terms of educating people or consulting sets that patient up better for rehab. Is that an accurate statement?
100%, I think. Being able to sort of predict what kind of a rehab candidate someone will be is one of our responsibilities. I mean, for PT, OT, and speech, right? Sometimes these patients are critically ill, they're just being evaluated, and the case managers are already like, are we talking long-term care or are we talking acute rehab? What are we thinking here? And those things change really frequently, but the case managers have to be starting to set this plan into place. Some of what I specialize in is disorders of consciousness and low-level cognition. So trying to determine which patients are, you know, appropriate for a disorders of consciousness program versus long-term care versus, you know, palliative interventions. You know, a lot of that plays a role too. And that just happens to be one of my specialties. But the PTs and OTs in the ICU play a huge role with that too. And oftentimes we're sort of having these conversations together. It really depends to what the patient's diagnoses are. I mean, a lot of times some of these like cardiac patients, for example, they look acutely terrible, right? So they've had like a CABG ×4, you know, and then they had all these sort of subsequent issues. They had difficulty extubating after the procedure. Then they ended up with a tracheostomy tube. A lot of these patients get significantly deconditioned because their heart hasn't been working right for however long, causing them to either have an acute event or to need this massive surgery. So there's sort of this precipitating course of weeks or months, and now they're like extra deconditioned. It can keep them in like a cardiothoracic ICU for a longer time. And that's one of the units where I'm like, none of these people should be eating. They just are so weak. They all have this junky cough. They all just kind of look like they can't breathe. So, you know, seeing them through their course of the hospitalization, initially thinking like, oh my goodness, they're going to need, you know, inpatient rehab. And then a lot of times they end up in sort of like an intermediate level of care. And then they end up on maybe the medical surgical floor. And then actually, you know, they're tolerating their regular thin diet and they're working with PT and OT and they're walking. So sometimes your initial estimations of what someone will be able to do is totally wrong, but you're keeping that conversation fluid. And I have found it to be the cardiac patients that tend to surprise me, where I'm like, oof, I just don't know if that person will ever eat again. And they end up like, you know, tolerating a diet and looking so much better because so many, you know, think about they've had that cardiac procedure now that so many things are improving, you know, their blood flow to their body, their muscles are getting stronger. They're having all of this other medical improvement, which we know corresponds to improvement in oral pharyngeal swallowing functioning based on the research. So
I can't help but feel like your knowledge base extends so far beyond what we learn in graduate school. Like in graduate school, I did not learn about heart and blood supply to the muscles and just think following the breadcrumbs about how much that impacts your job as an SLP. Is this something that you learn? I mean, I was going to make a bad joke and say through osmosis, but just like talking to nursing. And I mean, how do you get this knowledge? I mean, it seems like this knowledge is critical to your job in an ICU, but how do you 100%. Get it?
Yeah, I guess just over time. I mean, I also have a specific interest. I sometimes think I should have been like an ENT PA or something like that. I have a very particular interest in the way the body works and the way, I think Descartes, right? Descartes screwed us all up because made it so like now we're all specialized. We broke up the body into parts. It's like, no, you study this and you study this and you study this. And we kind of forgot about the way the body works as a whole, right?
As a whole, yes, exactly.
I mean, if you have respiratory failure, what happens? Your kidneys help to start to compensate to perfuse your blood with oxygen.
It totally blows my mind the way the body works together. So, you know, all of us kind of specialize in these areas, right? Like my fabulous ENT friends who like can take apart a larynx and a pharynx and understand exactly closely what it does. And, you know, us as SLPs, we understand so intricately the way swallowing works and the way communication works. But then you have to remember to kind of back up and look at the body as a whole. You have to look at your patient always as a whole and their environment as inclusion to their selves. So to think about when a patient comes in and their lungs start to fail, that their kidneys will go into hyperactive overdrive to try to help continuing to oxygenate the blood while the lungs are not functioning fully is just like fascinating. I mean, you look at the flora and the bacteria of the mouth and the impacts of, you know, not eating for a short period of time, and not just on, you know, the body's a bit, you know, not being able to swallow, but the fact that the process of eating and swallowing is cleansing out that bacteria and actively shedding the old skin of the tongue. I mean, this is just like mind-blowing stuff. It's so cool the way the body works. And that's why, you know, I love taking as high level CEUs as I can find. I mean, CEUs on the way the body works, and specifically pulmonary function, digestion. Yeah, if you ever sit down with a dietitian and they talk to you even about like the metabolic way in which TPN works, it's like, oh my gosh.
I don't even know what that is. Sounds
Yeah.
like some sort of, I don't even know what.
So it's when a person gets nutrition through their veins instead of through their gut. So there's so much.
That's possible? That's insane.
Oh yeah, it's possible, and it's expensive. So they have an IV port basically, and they get this clear liquid nutrition that their blood breaks down and turns into. It's basically micronutrition already, but the blood processes it instead of the gut. So
that's wild.
Right. It's fascinating. So that brings it on that whole interprofessional practice. Like you can spend 2 hours with a dietitian and say, holy crap, I just learned a bunch about swallowing through learning about the gut. It's fascinating.
And I feel like what you're talking about really highlights the benefits of a transdisciplinary team. So again, sort of like the difference between interdisciplinary and transdisciplinary. Transdisciplinary meaning when you learn from each other, when you're working cohesively, where there's a little bit of an overlap and a little bit of a blend between one professional's knowledge and the other professional's knowledge. And I feel like in your setting, in this ICU setting, this peer-to-peer education is critical because you're working with someone who's so critically ill.
Absolutely. ASHA's had a big push this year for this concept of interprofessional practice. And I was at ASHA recently and spoke a little bit about interprofessional practice. And the WHO defines it as more of a full understanding of what each other does rather than I do what I do and you do what you do, and we sort of work simultaneously. This interprofessional practice where I fully understand what you do and you fully understand what I do. So there's this dance that allows for a more cohesive look at the patient's chart. We just asked for an in-service from our GI colleagues to try to get a better idea of, what can the GI department do for a dysfunctioning UES? When is it appropriate to recommend potentially dilation or, recommend an esophagram versus an EGD. So, the idea of finding out more about what your colleagues do so that you're not putting in as many inappropriate consults or, specifically which physician to reach out to because they're the one who specializes in X, Y, or Z, or having a person you can reach out to with questions. Hey, would this be an appropriate consult or would you be able to look at this person? Based on knowing what you do, I would think that this would be a good patient for you to see. So, helping with efficiency within the hospital system and the medical system, and really getting patients faster, more accurate care. I think this interprofessional practice is totally key. And depending on where you work, it can be really, really fulfilling too, to work so closely with a team like that and with the patient and see good outcomes. It's really, really fulfilling.
Yeah, it just sounds like we always talk about how collaboration is a critical piece of our jobs, but in your setting, I feel like it's even more critical, just given the nature of the setting and how sick your patients are. And I wonder if in our last 2 minutes, you have any parting words or wisdom, parting thoughts for the SLPs who are listening and maybe interested in this setting or interested in learning more, or maybe already work in this setting, but are chomping at the bit to become more competent.
Yeah. I think finding a mentor is key, working with someone who you respect and has a foundation of clinical knowledge and years of experience. And, doing extra CEUs on the way the body works and the processes of the different systems and how they interact with each other. There's a lot of good CEUs out there on medication and what medication does to the body and therefore the impacts on dysphagia or functional communication. So if you're wanting more, start to look outside, maybe a little bigger picture to the systems of the body, and maybe start there and see what you find.
Thank you so much for all of your wisdom and sharing everything with us and for making these amazing handouts for people to download. You're clearly a master of your domain, and we're so grateful for your time. To everybody listening, the handouts that Sara made are available for free. There's a link to download them in your show notes in case you're biking, running, walking, or whatever. Sara, thank you again so much for joining us.
Thank you so much for having me. I really, really enjoyed this.
You're the best. Thank you so much for joining us in today's episode. As always, you can use this episode for ASHA CEUs. You can also potentially use this episode for other credits depending on the regulations of your governing body. To determine if this episode will count towards professional development in your area of study, please check in with your governing bodies, or you can go to our website, www.slpnerdcast.com. All of the references and information listed throughout the course of the episode will be listed in the show notes. And as always, if you have any questions, please email us at info@slpnerdcast.com. Thank you so much for joining us, and we hope to welcome you back here again soon. Another big thank you to our corporate sponsors, Med Travelers, who helped make this episode possible. Our corporate sponsors keep our CEU prices low and our program ad-free. Med Travelers is your industry leader for exclusive allied healthcare travel opportunities. Med Travelers has benefits like higher earning potential, W-2 employee status, and a flexible schedule. Visit medtravelers.com to learn more. Med Travelers did not participate in creating the contents of this episode.